Welcome back to everyone from your break. Our next speaker is Dr. Jonathan Arzt. Dr. Jonathan Arzt attended the University of California, Davis, where he simultaneously pursued and received his DVM and a master's in preventative veterinary medicine. He subsequently completed the combined program of residency and PhD in anatomic pathology at Colorado State University. He is a diplomat of the American College of Veterinary Pathology since 2005 and received his PhD in pathology in 2010. Dr. Arzt has been a senior scientist at the Agricultural Research Service of the USDA at Plum Island since 2006 as a veterinary medical officer. He works primarily in the investigation of pathogenesis and epidemiology of foot and mouth disease. Other research interests have included African swine fever, vesicular stomatitis, Q fever, and toxicoses among livestock of Easter Island. He is the author of over 100 peer-reviewed publications, mostly on FMD. So I'd like to introduce Dr. Jonathan Arzt with his talk on African swine fever and just a little classical swine fever.
All right, thanks very much for that introduction, and thanks for the invitation to speak. Yeah, I'm gonna mostly be talking about ASF, and depending on how things go, try and fit in just a little bit of CSF at the end. But lately, African swine fever is the rock star of transboundary animal diseases for reasons that most of you probably already know, and we'll talk about as we move through the presentation. And so let me first just mention that there is this list that all of you have seen in some form or another of the severe systemic disease syndromes that pigs suffer and the differentials that must be considered, and that there is this substantial overlap in the presentation of these diseases. And if you look down in the red, absolutely, when presented with severe systemic disease in pigs, the definitive diagnosis will always come from collecting samples and running first real-time PCR and other diagnostic modalities that are readily available. But of course, going back to the purpose and goal of this talk, ASF and CSF are on this list, and they do present in ways that have overlapping similarity to one another and to these other diseases, including various forms of salmonellosis and PRRS and erysipelas and other diseases. So just always keep that in mind, that none of these syndromes are completely unique or distinct to any one disease, in my opinion. So jumping in on ASF, African swine fever is caused by African swine fever virus. I'll be using ASF and ASFV repeatedly. I'm sure those are familiar acronyms. And it is a severe hemorrhagic disease of pigs. It is highly contagious, often fatal. I rejected the term hemorrhagic disease for a long time because I think ASF manifests in a lot of other ways also, and it's a bit of a misnomer, but in terms of considering it differentially from the other diseases on the list, it certainly is a prominent component of ASF, the hemorrhagic presentations. So virology, basic virology a little bit, ASF caused by ASFV. It's the only member of the family Aspergillosis. It's an icosahedral enveloped double-stranded DNA virus. It's quite a unique virus. It's the only DNA arbovirus. It's gigantic and often compared to pox viruses in some regards. It's about 200 nanometers in size with a genome of about 180 kb, which includes up to 160 ORFs, each of which is probably or maybe a separate gene. They haven't even sorted that out yet. Historically, this was a disease first identified in sub-Saharan Africa, but it's very much a disease and a virus on the move. And just a bit more on the structural aspects of the virus. There's more than 50 structural proteins, and there are more than 150 proteins total, which is quite phenomenal for people that are more accustomed to working on RNA viruses. There are no distinct serotypes of ASFV, but there are these two distinct genotypes that are relevant to current epidemiological phenomenon. So a bit of the historical and current epidemiology of ASF. It was first identified in 1921 in Kenya and subsequently identified throughout much of sub-Saharan Africa. There are various historic excursions from Africa. The earliest one really was in the late 50s, early 60s, when ASFV made its way to Portugal. And it persisted there until about 1995, actually. Moved around in Spain as well, in Sardinia. And then subsequent to those outbreaks that ultimately were controlled, there have been sporadic spread to various European and South and Central American countries, and notably Caribbean countries as well, and particularly Cuba and the nations of Hispaniola, to include Dominican Republic and Haiti, where it has come back again, as we will be talking about. But really, in terms of what's going on in the world now, it sort of all began in 2007 when ASFV was introduced into the Republic of Georgia, and it traversed across the Caucasus, made its way north and westward in Russia, reached the EU borders in 2014, made its way into Poland, Germany, Belgium, and is causing quite a bit of unsettlement in Europe, still with continued expansion. Another big move was 2018, when ASF was detected in China. And from the 2018 China incursion, the virus made its way through many nations in Southeast Asia and South Asia, including India, Vietnam, Korea, Laos, and Cambodia, other nations in that region. Now, nothing much happened beyond that regional spread until 2021, when ASFV was detected in the Dominican Republic, and then late 21 or early 22, it was subsequently identified in Haiti as well. And this now is a huge problem for those of us in North America. And the virus is very much not controlled and continuing to spread across that island, and reminding us how precarious our borders are in the current era of global movements. So here's a view of global status of ASF in 2018 as the virus is making its way westward from Russia into the EU and making its way across Asia. Now, 2020, a couple of years later, you see more movement westward, more spread across Southeast Asia and South Asia. And now 2021, here you have Hispaniola in the lower right, Haiti and the Dominican Republic, all these individual outbreaks. Essentially, the entire island should be red at this point. Cuba at this point has not had any outbreaks, but thinking about the distances, Haiti to Cuba and then Cuba to Miami and the Bahamas, the distances are quite small and the vulnerability is very real. And the United States is investing a lot of effort to try to help control the ongoing outbreaks in Hispaniola. So let's talk about hosts. The only animals that get ASF are suids. There are reservoirs that, tick reservoirs that are highly relevant, both in the classical and more recent geographic spread. In Africa, the typical host species have been the bush pig and these giant forest hogs and warthogs, which all have asymptomatic infection in the sylvatic cycles. But the virus has also, over the years in Africa, made its way into pigs, domestic pigs and wild boar that have very similar symptomatic and varying severe syndromes that we're going to talk about in great detail. The reservoirs are classically the ornithodoros ticks, but also other arthropods can serve as mechanical vectors, including Stomoxys and other biting flies. So here's a nice view of one of those big fat ornithodoros ticks. There is transstadial and transovarial transmission, as well as sexual transmission across ticks. And ticks apparently do remain infected for the duration of their lives, and can be maintained in tick colonies for years as well without subsequent introductions. So you hear a lot about the different transmission cycles. And if we start off looking on the left, and particularly the lower left, this S here for sylvatic cycle is the real original classic cycle, and there are plenty of representations in the literature that still represent this sylvatic cycle as being the only relevant manner of transmission. And the sylvatic cycle is this cycle between the reservoir ticks and the asymptomatic hosts in Africa, the wild suids. And that is largely how the virus was maintained classically and still continues to be the case, but in the current era, things have changed quite a bit. And so these ticks, of course, also will land on domestic pigs and cause distinct cycles of transmission, either tick-pig cycle, but once those domestic pigs are infected, then we move over to the right side where these domestic pigs then shed high levels of virus. And so over on the right side, I'm calling this the domestic cycles, where you still have the tick-pig direct transmission, but also real direct contagious transmission amongst pigs. And so the TP and DT are all occurring at the same time. This is what really is the most relevant manners of transmission, particularly direct pig-to-pig transmission, which is what is mostly resulting in the widespread movement of this virus at this time, both in Asia, Europe, and in Hispaniola. Transmission routes are similar to many infectious diseases, including arboviruses, as well as directly contagious diseases, and transport of infected animals, live animals, resulting in direct contact between wild and domestic or domestic species. Additionally, the movement of infected pork products has been a huge issue, particularly in the westward spread towards the EU. Illegal movement in particular of pork products, which is probably how it got into Hispaniola, and food waste containing those pig products. Fomites, vehicles, humans, mechanical vectors of all manners are relevant. And of course, infected ticks moving about. And I'm not going to talk much more about the tick cycles, but it is relevant in certain places. And we do have competent ticks in North America, as well as in Europe. It's not just the native ticks, classical ticks in Africa. So we'll talk now about pathogenesis of the contagious cycles of African swine fever. This box on the left reminding me that you really do have to remember that you know, we try to build these timelines and tell you when things happen, but there's a lot of variability that is caused both by the viral factors as well as host factors, and in particular the strain of virus, the dose of virus that an animal is exposed to, and the route by which they're exposed, as well as the genetic background, of course. And so the timelines are rough guidelines, but relevant to think of nonetheless. So infection typically in the contagious cycles occurs either through ingestion or mucosal exposure of the virus. The upper respiratory or upper GI tract are the sites of infection. Primary infection occurs in the range of 24 to 72 hours after infection in the tonsil of the soft palate classically, or the malt tissues of the upper GI, upper respiratory. And then the virus quickly moves to the regional lymph nodes. From primary, then through blood as well as lymphatics, the virus moves either as free virus or with associated monocytes, macrophages, dendritic cells. There's limited secondary replication that occurs probably in the range of 3, 4, maybe 5 days, but very quickly then the virus goes fully systemic. There's full dissemination. Virus can be detected in essentially every tissue associated with viremia. So the most critical aspect of pathogenesis that is, well, relevant and largely unique to ASF is this distinct tropism for cells of the phagocytic mononuclear system. And that is the case in all tissues. And so there you will hear mention of virus being detected in renal epithelial cells or pulmonary epithelial cells. And there's a lot talked about endothelial cells. I have spent a lot of time working on this virus myself and trying to localize it. I've never been able to find it in any cell other than mononuclear cells, macrophages, dendritic cells. And so typically when the virus is present in various organs, it's present within the lymphatics or blood or resident mononuclear cells in those tissues. Here's a view of ASFV in the tonsil of the soft palate of a pig during fulminant infection. The ASFV antigen in red is seen co-localizing with that turquoise color, which is the CD163 marker, said to be a scavenger receptor and believed to be either the main or co-receptor for ASFV. And the cytokeratin staining here, the green, is nice because you see the real sparing of the virus. Even when the virus is within the epithelium, it's not in epithelial cells. It's in these CD163 positive cells. A few more views, similar but different. Bear with me, I'm not advancing now for some reason. Okay, yeah, so here's a view of the virus in the lung. And here now we have cytokeratin in the turquoise stain, and ASFV again in red. You have blood vessels, von Willebrand's factor in green. And again, the red is not localizing with either the endothelial or epithelial markers, but rather localized to these distinct mononuclear cells. In that case, mostly alveolar macrophages. So the infection of monocytes, it's where ASFV replication occurs. It results in various forms of manifestation microscopically. You can see range of hyperplasia to necrosis, depending on the phase of disease. You will see mention of the resultant hemorrhage being associated with mononuclear cell replication. I believe there is some causality there, but I've never seen a good explanation of how exactly that occurs. Some catchphrases that you will hear associated with ASF are this heme absorption phenomenon, which was the classic manner in which the infection was diagnosed. That occurs in a unique sort of virus isolation in which red cells, erythrocytes, are put on top of a monocyte culture, and you see this heme absorption between the monocytes and the erythrocytes. You'll also hear about this cellular remodeling and virus factory phenomenon. That's an EM phenomenon that is often discussed and described in ASFV virology. So clinical syndromes, there are various syndromes that you will hear described. They are not exactly unique, but they are a continuum, but it's useful to think about these different forms. The different manifestation will depend on the virus isolate, the route and dose of infection, and host factors, as I mentioned. The classification of the syndromes, again, a continuum. There's this peracute form. There's the acute disease form, which is really the most relevant currently circulating, and it's the form that you will see associated with the classical lesions. There's also subacute form as well as chronic forms of infection. So quickly talking about the peracute form, this occurs with highly virulent strains and very high doses. It's a very rapid and lethal form of African swine fever. You'll see a very high fever, very rapid onset. You'll see classical signs of systemic disease, including loss of appetite. and lethargy. You'll see cutaneous hyperemia, and these animals can die as early as 1 day after infection, but typically they'll die, certainly most of them, 90% or more, will die within 5 days after infection. You will see very little of the classical visceral lesions. They don't have time to develop thrombocytopenia. If it occurs in pregnant sows, then you may have abortion in the peracute form. So the acute form, as I've mentioned, is really the most common and relevant manifestation under current scenarios. You will have a similarly high fever, going up to 40, 42 C, can go up to 106, 107 even Fahrenheit. You'll see huddling pigs, loss of appetite, apathy, inactivity, and you will see these hemorrhagic syndromes. Essentially, you can see hemorrhage anywhere in these pigs. The classical manifestations are in the GI tract or in effusions, but you can see epistaxis, hematemesis, hematochezia, melena. These animals will have severe pulmonary edema and they may die in respiratory distress, but really the most common way that they die is hypovolemic shock. So the animals, after 2 or 3 days of the severe systemic syndrome, will start to crash, and you'll see them dying in shock if you don't have to euthanize them sooner than that. Typically 7 to 10 days will be when these animals die. As they're in their later phases, you'll see cutaneous erythema, various locations, ears, tail, extremities, and the ventral portions of the thorax and abdomen are classical. As that progresses, it may become cyanosis rather than erythema. You may see abortion with the acute form, and this is highly fatal. Approximately 90 to 100% of pigs with this form of ASF will die within about a week, maybe 10 days. We'll go through some clinical and then necropsy views of acute African swine fever. Here we have a highly to moderately virulent virus. You see the high fever causing the pigs to group up, huddling together, and ultimately dying with various forms of hemorrhage. Here are some better views of epistaxis and melena. Here's some views of the erythema, of the tips of the ears, tail, distal extremities, chest or abdomen. And here's a more advanced form, more cyanotic lesions as it progresses. So pathologic lesions of the acute form, these are really the classical lesions that you've probably heard about and seen already, largely associated with effects on the lymphoid system and hemorrhagic manifestations of disease, including the erythema, cyanosis, various forms of hemorrhage, vascular changes. The splenomegaly is one of the classic lesions, and it can be very prominent and impressive. Some of the biggest spleens I've ever seen, up to 5-6 times normal size. Hemorrhage, congestion, and necrosis of lymph nodes is a classical lesion, and you'll hear mention of renal lymph nodes and gastrohepatic lymph nodes. Those definitely are consistently affected, but really it can be any lymph nodes, and so don't believe the hype that those are the only ones that are affected. Renal cortical lesions are fairly common. They can exist in a continuum ranging from petechia, ecchymosis, or even diffuse hemorrhage. You can have hemorrhage in other sites, mucosal sites and serosal sites, including urinary bladder, epicardium, endocardium, pleura. Here's a view of lymphadenomegaly. These are the submandibular lymph nodes of a pig. This was Malawi strain of ASFE about 5 days after infection. And here's a microscopic view of that lymph node. Microscopically, these lymph nodes again, can have either predominance of hyperplasia, necrosis, or a combination of both at the same time, as you see here, this monocytic hyperplasia and infiltration, as well as pycnosis and apoptotic bodies. Excuse me. Here's a view of those gastric hepatic lymph nodes. And they definitely are prominent and impressive lesions, and pretty consistent with acute ASF. Here are some views of the continuum of changes that you can see in the renal cortex, petechia on the left, approaching ecchymosis and diffuse hemorrhage on the right. On the cut surface, it's largely limited to the cortex. Here's another view, which would be a good view for a board exam, containing both the renal cortical hemorrhage as well as the renal lymph nodes lesion. So the renal lesion microscopically, there will be glomerular hemorrhage and necrosis and capillary infarction. You can also see this interstitial sort of dissecting hemorrhage at any level of the kidney, but mostly in the cortex. Tubules also, you see hemorrhage as well. Another view, less specific, but pig, cyanosis, melena, ASF. More lesions of hemorrhagic GI contents, really not ASF specific, but if you see something like this and somewhere in the image you can make out an enlarged or congested hemorrhagic lymph node, you definitely should be thinking ASF. CSF can manifest with various forms of hemorrhage, but it's just not a classical aspect of the disease presentation the way it is with African swine fever. Here's a couple views of the splenomegaly. And a microscopic view of splenic congestion, hemorrhage, necrosis, lymphoid atrophy, classical ASF spleen lesion. You will see pulmonary edema in these animals. In my experience, it's not typically the cause of death, but it is also not rare either. Prominent interlobular pattern of the lungs, pulmonary edema with ASF. Microscopically, you may see some of the monocytic hyperplasia, but otherwise it's sort of a typical pulmonary edema, proteinaceous fluid filling the alveolar spaces with varying degrees of congestion and hemorrhage. Here's a view of the pulmonary edema combined with some pleural effusion. Cavitary effusions, for some reason, tend to not be hemorrhagic. They tend to be more straw-colored, typical ascites, pleural effusion, transudate, or slightly blood-tinged. They can range to be real hemorrhagic effusions, but the effusions, I would say, more often are blood-tinged and transudate-like. Gastric mucosa, hemorrhage, abortion can occur. Typically, you can see a continuum of changes depending on the viral strain, but typically they're normally formed fetuses that are aborted, more associated with the fever and cytokine storm rather than transplacental infection. So that was the acute form. Moving on to the subacute form, which is largely similar, but the biggest difference in subacute is that these animals survive longer and have a chance to develop some more fulminant lesions and some slightly distinct lesions. The vascular changes can be more severe. You can have more impressive edema and cavitary effusions and hemorrhage just because the animals live longer to let it develop. You will have an intense but transient thrombocytopenia in the early and mid stages of disease. Again, you can have abortion associated with the systemic disease, not transplacental infection. In subacute form, typically 50 or 70% of the pigs will die. It can range up to 100% with some strains. They typically live longer. They can live 10 to 20 days, and some pigs may survive, again, depending on strain, virus, and host factors. But for the full duration of infection, the animals are shedding large quantities of virus. Subacute form, the ultimate death can be due to the similar causes as described with the acute form. It can be associated with the thrombocytopenia or leukopenia in the early stages. And later stages, it tends to be more similar to the acute form, to the typical hemorrhagic or chronic inflammatory syndromes. These pigs also may develop secondary infections that may confound diagnosis. This is a pig with subacute African swine fever, non-specific findings of secondary respiratory infection, nasal discharge, and other GI syndromes may occur, non-hemorrhagic diarrheas. In the subacute form, the pathology, as I mentioned, may be more impressive. There are some lesions that are sort of unique to the subacute form, like this gallbladder mural edema, and the retroperitoneal edema also are typically associated with the subacute form. You may see infarctions, although it's not a classical manifestation the way it is with classical swine fever. But these other findings in lymph nodes, various lymph nodes and hemorrhages, very similar to the acute form. Here's some views of some of the more novel vascular changes associated with subacute. As I mentioned, the cavitary effusions may be more impressive in quantity. They can be tricavitary or any individual component, ascites, thoracic, pleural effusion, or pericardial. The gallbladder edema, I'll show you some images of that. And here on the right is a view of the retroperitoneal edema, which is quite impressive at times, and in my experience, quite unique to ASF. Here's the gallbladder edema. On cut surface, it really is quite impressive. And it probably occurs with other diseases as well. I've only seen to this extent with ASF. Okay. So chronic form of ASF. There really are not specific clinical signs. Even the pathologic signs are pretty nebulous. You can have typical sort of failure to thrive in growing pigs. You can have emaciated pigs with secondary infections, either GI or respiratory or other. It's typically a low mortality form. And there really is almost complete absence of the classic ASF lesions. It is believed that the chronic forms of ASF have occurred through evolution of vaccine strains, live attenuated vaccines that survived long enough and started to circulate and become these low virulence forms. This was particularly a problem in Portugal and to lesser extent in Spain. This is currently not occurring in any of the ongoing pandemic or outbreak scenarios, but it is noteworthy. It is in the literature and it should be known to exist. Also, this last bullet is relevant that throughout the chronic form, these animals are shedding large quantities of virus, which is somewhat counterintuitive from other presentations, aspects of the disease. I'll show you some of the lesions associated with the chronic form. There are these necrotic skin lesions. There can be various forms of arthritis and periarthritis. You can have fibrosing serositis and adhesions. You can have chronic pneumonias and GI syndromes, and you can have necrotizing lesions of tonsils or of the tongue have been reported. Here are these chronic skin lesions. They certainly look like infarcts. I don't think it's ever been determined one way or another what the pathogenesis is, but they are commonly reported with the chronic ASF syndromes. Here's some fibrosing pleuritis and serositis. So diagnosis of African swine fever, of course, you make your presumptive diagnosis based on your epidemiology and clinical signs and your gross lesions. But as I mentioned from the very start, your confirmation absolutely has to come from molecular tests, and real-time PCR now is certainly the most common, readily available and useful test. Historically, there have been other diagnostics in widespread use. In particular, the virus isolation hemoabsorption test was one of the earliest. Various forms of fluorescent antibody tests as well, and of course histopathology and with IHC, IFA can be useful as well. And I don't mention sequencing here, but of course rapid next generation sequencing now is also an important modality of diagnosis. Control and eradication. There is currently no licensed vaccine in the United States. As far as I know, elsewhere, perhaps China is maybe using vaccines. I don't think they are very forthcoming about it, but it is sort of widely believed that they're following similar paths as the past, using live attenuated vaccines, which has been typically the most successful manner of developing vaccines, but it's tricky. Reversion to virulence is a big problem. But there are various efforts underway globally developing a lot of different types of vaccines as well, and some experimental vaccines which have been deployed in places like Vietnam and some other locations as well. So now, with just a little bit of time to play with, I did feel that I couldn't walk away from this talk without talking a little bit about CSF, hog cholera, as a contrast to African swine fever, but also because of its significance as a global systemic transboundary disease threat for pigs. So CSF, similar to ASF, the hosts are only suids. It's a highly contagious and often fatal, economically significant disease of domestic pigs and wild suids. Like ASF, it is an OIE reportable disease. CSF is caused by classical swine fever virus. It's a member of the pestivirus genus and the family Flaviviridae. The typical pestiviruses are quite familiar, and CSF, along with BVDV and border disease virus, are the most important members. And since I'm not going to have much time to talk about CSFV, a lot of the things that you already know about BVDV or border disease, a lot of them can be translated across to CSF in pigs. So transmission typically occurs in endemic cycles. It's a highly contagious, directly transmissible disease. It occurs with introduction of infected pigs or with movement of wild suids. In contrast, like other transboundary disease, outbreaks in previously CSF-free regions are typically associated with movement of contaminated pork products, with humans, with vehicles, with different types of fomites, and illegal movement of food and garbage feeding. Infection of pigs typically occurs via the oronasal route. Direct or indirect contact with infected wild or domestic pigs, or fomites, or other manners of indirect transmission of the virus. The oral infection by ingestion is often associated with contaminated feed. Also, semen, blood, tissues, secretions, excretions moved intentionally or unintentionally often result in outbreaks. Again, mechanical vectors. And the virulence of the strain can absolutely influence the spread of the virus. And that is largely due to differences in quantity of shedding and duration of viral shedding. So the clinical and pathologic presentations, similar to ASF, there are distinct forms that you will hear discussed. In reality, there is a continuum across different forms of clinical manifestations, but you can think of it as being broken into the acute and chronic form, which again is dependent or defined by both viral as well as host factors. But really, for the most part, we're talking about domestic pigs, and we're talking about low virulence strains infecting domestic pigs and causing chronic, prolonged, or even completely subclinical infection. And if there's one bullet for CSF that is the most practically relevant aspect, it is that for CSF, this issue of low virulence strains is very real, prominent, and it's one of the great threats of CSFV as compared to ASFV. There are low virulence strains spreading in endemic places that we know of, but also probably in places that are not even known to be endemic. And if and when CSFV makes its way into the CSF-free regions, it probably is going to be associated with these low virulence strains. And once they get in, they can spread quite widely before you even detect them. Reproductive syndromes, unlike ASF, CSFV does infect the transplacental infection of fetuses and can cause the full range of syndromes that you've heard described for BVDV and BDV. And the presentation, clinical presentation, as well as pathologic presentation, can vary greatly depending on the viral strain and the host factors, as I've just described. So there've been a lot of good review papers lately, and I don't feel too bad not being able to talk more about this disease, because there really has been a lot of attention to CSFV and comparisons between CSF and ASF. This Blom presentation publication from 2017 is a very good one and provides a very good summary of the distinctions between acute and chronic forms of CSF. Unlike ASF, there are a lot of vaccination options available for CSF, and these spread the full gamut of types of vaccines. First vaccines, like many other diseases, were traditional inactivated viral preparations, but over the years there's been development of a lot of variations on subunit vaccines, as well as live attenuated. There are options available for oral baits and vaccination of wildlife. There are vaccines that have DIVA components that often are paired with specific diagnostic tests. And so the choice of a vaccine in a particular region will depend on the goals. It'll depend on whether you're dealing with endemic disease, or outbreak. It'll depend on whether your goal is eradication or just control of clinical disease, and it will also depend on the need that you have to return to CSF-free status. So with that, I think I'll wrap there and open up for questions. I did have a lot more slides moving forward with lots of images of CSF, but since time is running out, I think we'll cut it there. And I don't know if this presentation can be shared to the participants, because I did intentionally keep a lot of these other good images in here that would be helpful for people. Okay, I'm going to leave it at that. Thank you.
Thanks, Dr. Arzt. We do have one question in the Q&A. If anyone else has any questions, please feel free to pop them in the Q&A now, and we'll try to get to them and finish up on the hour. Would you like me to read Willie's question to you?
Yes, please.
So Willie Suan asks, how much of the hemorrhagic lesions of ASF do you think is caused by coagulopathy versus vascular change, or both equally contributing to the hemorrhages? Thank you.
Yeah, you know, I'm very disappointed in the entire scientific community for not having sorted those questions out more thoroughly. And I've often wondered myself, and it's never been my specific area of research. Certainly the thrombocytopenia is part of it, but there really has never been, in my opinion, a good demonstration of what is the etiology and pathogenesis of the hemorrhagic syndromes associated with ASFV. I'm sorry, I wish I had a better answer for you, but that's the truth.
We've got a question from Javier Sinros, who says, great presentation, thanks a lot. Could you please develop a little bit on the strategies you have used, techniques, organs tested, etc., to try and identify ASFV within endothelial cells?
Yeah, so it's been fluorescence microscopy has been my mainstay, and I've spent a lot of years developing such techniques, mostly for FMDV. However, we translated a lot of that. We had good immunolocalization of various ASFV antigens, and we would do these simultaneous multi-channel immunofluorescent views, some of which I showed you. We would use different markers for endothelial cells and different markers for ASFV, and other markers as well, up to 4 or sometimes 5 distinct markers at the same time. And really, I have never been convinced of localization of ASFV to endothelial cells. I would make the same comment about epithelial cells. And I really have invested a lot of time into that. And one might suggest that you would have to do it with more strains of ASFV, and perhaps there are strains that are endotheliotropic, and that I have not indulged to a great extent. I've tried about 3 different strains of virus, and so that has been my approach. Looking, I should have mentioned that all of that work being done in experimentally infected pigs at different stages of disease. So I haven't done any work in cell culture. I'm talking about experimentally infected pigs with different strains. That has been my approach.
We've got a question from an anonymous attendee who asks, is it possible to have co-infection between ASF and CSF?
Sure. I don't know that I've ever heard of that naturally occurring. I know people have done it experimentally. You could imagine that either of the diseases in the chronic low virulent form, those pigs could be susceptible to superinfection. I would not expect it to be likely in the acute and virulent forms of either disease, just because of the unlikely unlikeliness of temporal alignment of the infections, but also the pro-inflammatory cytokine storms that are occurring and associated with either one of those diseases individually. It's hard to imagine that they could become super infected with the other virus.
And one last question from Vetnisa Wanyantito, who asks, which pathological characteristic would we expect to find in co-infection of both ASF and CSF?
Well, yeah, I mean, similar question. I mean, the possibilities are sort of endless. I think it would have, in my opinion, it would have to be a low virulent form of one of the viruses, followed by a highly virulent form of the other virus. And I think that it would be the highly virulent superinfection would be the lesions that you would see. So if you had chronic CSF and then subsequent acute ASF, you'd be seeing classical, for the most part, classical ASF lesions, and vice versa. I would make the same comment. I'm speculating though. I would want to think about that some more. And I honestly, I don't think there's a definitive answer, but it's a good question. Both those last two questions.
Okay, thank you very much, Dr. Arzt, for a really insightful and thought-provoking presentation. We've got quite a few thank yous, and in particular, thank you for staying up despite the time difference as well. So really fantastic talk.